Hi, I'm Dr. Townsend, and we're going to go over puberty, normal, precocious, delayed, and abnormal or dysfunctional uterine bleeding due to anovulatory processes. Just do a brief overview of this from your readings. Normal puberty, first sign of puberty in males usually begins between age 10 and 12 and is scrotal and testicular growth. The growth spurt begins about 2 years earlier in girls than in boys, and gynecomastia is common in young teen males and usually disappears within 2 years. People will come in and they'll be rather upset about this, but this usually goes away. Normal menstrual cycle, according to the American College of Obstetrics and Gynecologists, normal menstruation in adolescents usually occurs between 11 and 14 years of age. The average age of menarche in the U.S. is approximately 12 and a half years. With that, understand you'll see some stuff in the reading anywhere from 12 to 12.7, 12.3. Anyhow, you get a general idea, 12 and a half. Menarche can begin as early as 10 or as late as 16. Normal menstrual cycle length is 21 to 45 days, lasting as much as 7 days. So as we know, we typically think of a normal menstrual cycle being about 28 days. However, it's still considered normal if it falls into the 21 to 45 day span. Go back and do a little bit of review of your Tanner stages of development, just so you know kind of what is normal. You didn't know what's normal to know what's abnormal. So you'll find that helpful. I just included this here, but it's also in your book, in your readings. And you'll see the penis and the scrotum, the growth and development, and the pubic hair, the breast development. We move on to precocious puberty. Girls, precocious puberty occurs if the onset of secondary sex characteristics are noted before age 8 in Caucasians and 7 in African Americans or Hispanics. Boys are considered to have precocious puberty if they have secondary sex characteristics before age 9. You're more likely to have precocious puberty in girls than in guys, and it can occur earlier, but a lot of times if it occurs at age 6 to 8, it can be thought to be because of obesity. We've now got a national epidemic of obesity, so this can be what's going on. So don't panic if someone presents or that's the complaint initially, the chief complaint. Watch the growth charts for unexpected changes. Important to note that while children with precocious puberty may be real tall for their age, their adult height is often shorter than expected. Not always, but can be. It can be compromised. How do we know puberty is occurring early? What are the physical signs? So what are the physical signs of puberty? Progressive breast development, rapid growth acceleration, and early menses, usually around 2 years after the appearance of breast. So that's what occurs in the girl. Boys, penile and testicular enlargement, increased musculature, and hair, body hair, rapid growth, acceleration, and voice becomes deeper. Okay, you got precocious puberty. You got 2 main categories. These broad categories are central, GnRH dependent, and peripheral, GnRH independent. Central precocious puberty, most common, is pretty much identical to normal puberty. It just is an earlier onset. The clock's revved up a little faster, so they start a little earlier. Peripheral precocious puberty is triggered peripherally by independent release of endogenous estrogens or androgens from the adrenal gland or gonads, or by exogenous exposure to sex steroids, your initial workup of precocious puberty. You want to make sure you're taking a good history. Like, when did y'all notice this occurring with this child? Look at the growth chart. Ask some good questions from the parents. Try to see if this is really what has actually happened. Make sure you're looking at that growth chart carefully. You want to order an x-ray of the left hand and wrist to check for bone age. This x-ray will provide you with information as to how far along the child is in puberty, how quickly puberty is progressing, and this can affect the child's height the child reaches for adult. Obtain some basic blood work. You're going to check pituitary hormones controlling puberty, like your LH, your FSH, your sex hormones. You evaluate estradiol, can point to a possible ovarian cyst or a tumor for female. If the blood test shows central precocious puberty, then you want to get an MRI of the brain to check for underlying abnormalities of the pituitary gland. Remember, precocious puberty, the goal is treatment of central precocious puberty is aimed at halting the progression of premature sexual development and slowing linear growth and skeletal maturation to improve the child's final adult height and promote psychological well-being. Now remember, I'm going to say this to y'all, if you have a young male or a young female and all of a sudden, they're really young, they're 6, 7 years old, and say the young female and she's 6 or 7 and she's getting breast. None of her friends are getting them. Psychologically, that's going to have an emotional impact on this child. She doesn't want to be different. Let's be careful how we approach this. Let's be very sensitive to both the child and the parent. And so be careful in how you approach it. Precocious puberty. You want to get that x-ray of the left hand and wrist again to determine bone age. If central precocious puberty is diagnosed, then an MRI needs to be done of the brain to rule out central lesion in the brain. Girls with central precocious puberty can be treated often with GnRH analogs, the leupride, peripheral, depends on the cause. Boys, if it's central, you treat with GnRH as well. Girls, if lab test indicates peripheral puberty, then you may need to obtain ultrasound of the ovaries and the adrenal glands. And you can see the x-ray of the left hand as they're checking for bone age. And here you have causes of precocious puberty and the differential diagnoses. So this gives you some idea of what you look at, your concerns. Takeaway point here is you begin the workup for precocious puberty, but if you believe that you have a true case of precocious puberty, you're going to be managing this case along with the pediatric endocrinologist, unless you're in a pretty advanced pediatric practice. This is not going to be just general family practice. You may be co-managing them, but you need to refer this patient. Delayed puberty, basic workup. We're back to that x-ray again. X-ray of the left hand and wrist to obtain bone age. Delayed if the bone age is less than 12 years. Next, you're going to check some labs, FSH, LH. You're going to get those hormones. And you may want to get some genetic tests for chromosome disorders. Bone age greater than 12 years. If no physical signs of puberty. If gonadotropins are elevated, then they have primary hypogonadism or testicular failure. Turner syndrome, Klinefelter's, these are the most common causes of primary hypogonadism. Delayed puberty. The thing to think about here is constitutional growth delays. I call them late bloomers. There's probably another term, but I call them late bloomers. When you're thinking about these children, these can be your kids that are competitive athletes, your gymnast. We've got, you have them running cross country. They're playing all these competitive sports that are very aerobic in nature, and they're in dance teams. Or you may have a child that has been sick for whatever reason and has had to be in the hospital for long periods of time because they've been acutely ill for quite a while. They may have constitutional growth delays because they've just been so ill they haven't gone through puberty because of that, and that's normal. So bear that in mind and remember that. But primary hypogonadism, you will see no pubertal sign by age 13 or menarche by age 16. Can be primary or secondary amenorrhea. Primary hypogonadism, most common cause is Turner syndrome in girls. Boys should be evaluated if no secondary sex characteristics by 14. And hypogonadism, most common form in males, is Klinefelter syndrome. Hypogonadal patients will need to be placed on estrogen or testosterone, depending on male or female, to help prevent osteoporosis. So, these are Turner syndrome or Klinefelter syndrome are two forms of primary hypogonadism, common forms you'll see. So if you're not seeing those pubertal signs in girls, by 13 or menarche by 16, then you're going to be concerned. When you think about Turner syndrome, here's a little something to look at. The data, it's a little confusing depending on where you read to try to figure out how prevalent Turner syndrome is in a population. You'll get anywhere from 1 to, I think this is supposed to be 2,000, not 200, so sorry, forgive me for the typo, to 5,000. Most of the time what I'm getting is about 2,500 births, somewhere around there. So it's not real common, but you will probably see it. The biggest thing you'll notice is the female is short-statured and may have webbing of the neck. And depending on the exact makeup of the chromosome or configuration will determine how prevalent the features are. They can have some ear malfunctions. You can have some heart issues. There can be lots of different little things that this young woman may have that may be little problems for her. But biggest thing will be short stature, and she will be infertile. Klinefelter syndrome, this is a male. He will usually be tall, usually a very thin or small chest, narrow chest, I believe is how it should be described, and wider hips. Those are things, and the female type pubic hair pattern. So you may see this. It's a little more prevalent, I believe. Might be 1 in maybe 1,000 to 1,500 or so. Anywhere it varies with what you read, anywhere from 1 in 500 to say 1,000. You'll see that. You don't have to know how prevalent. This just might be for your own interest if you want to know. But these individuals with the primary hypogonad, the most prevalent form, both of them, they are sterile. So be very careful and thoughtful when you're doing your interaction with the parents and with the individuals, because they're coming to you as an adolescent, this is a difficult time. There's a lot of change going on emotionally and physically, and no one wants to be different. So be very supportive. And this just shows you the karyotype. As I said, the Klinefelters, there's some disagreement as to how much it is. You don't have to know that, but this is just to let you see what it looks like. We're going to go over the abnormal uterine bleeding due to anovulatory cycles, sometimes called dysfunctional uterine bleeding. You'll see it both ways, depending on where you're looking. And then there's further delineation from the abnormal uterine bleeding. So don't get upset. Just in general, that's what you need to know. It is irregular cycles, short cycles with scanty flow or periods of amenorrhea due to alterations in the hypothalamic pituitary axis. The corpus luteum is not formed, failure of the cyclical secretion of progesterone, continuous or unopposed production of estradiol, stimulates the overgrowth of the endometrium, and the endometrium grows thick, outgrows its blood supply, it becomes necrotic, and you'll get some irregular bleeding, or you get some spotting or heavy bleeding. Make sure you can take a menstrual history. I know you've already had that this semester. Y'all have already gone over some of this. This is real important. Take an accurate one. Know when people's last menstrual period is. I can't stress that enough to you. You need to always know this with any childbearing age female. Once they hit puberty, you need to start asking every visit. It will impact your care. So, enough said. Anovulatory or dysfunctional uterine bleeding, approximately 95% of dysfunctional uterine bleeding in adolescence is due to anovulation. Without ovulation, there's no progesterone is produced from the corpus luteum of the ovary, leading to a state of unopposed estrogen. Unopposed estrogen causes the endometrium to overgrow, and it becomes excessively thick and unstable, and the lining breaks down irregularly and unpredictably. This leads to heavy bleeding and prolonged menstruation. You'll see variations in the percentages, so don't panic about that. Just have a general idea. Make sure you've done your readings on this. In general, as we go over this again, you want to know that in adolescence, when they're going through puberty, the hypothalamic pituitary axis in adolescence, it takes a while to mature. Bottom line, you'll get anywhere from 2 to 5 years, they'll say, for it to fully mature. And usually, maybe 82% of them, when they have this problem, is just because of the immaturity. This percentage will vary too. Don't panic. That's not that important. Just have this general idea of this concept. Assessment, make sure they're hemodynamically stable. That's the key, okay? You don't want them bleeding out and crashing on you. So make sure they're hemodynamically stable. How do you do that when you're just looking at them? Do they have any pallor, tachycardia? Do they have a murmur? You might have to do a pelvic exam. It might be required based on the severity of the problem. Go back to that history we were talking about, that you're going to ask them. Or you might have to refer them to GYN or hematology, depending on how severe or what you're dealing with. Treatment plan, you're going to get a menstrual calendar. You're going to assess for anemia or possible clotting disorders. If bleeding is severe, do they have von Willebrand's? It's more common than you might think. Initial labs. Pregnancy test. Make sure they're not pregnant. Some of them will surprise you. They really might be. CBC, PT, PTT, TSH, fibrinogen level, and iron studies. Going on with this treatment plan. Treatment plan is determined by the hemodynamic status and degree of anemia of the patient. Okay? This is what determines what you're going to do, how anemic that patient is. So in general, you're going to give them iron supplementation, NSAIDs, and birth control pills, okay, oral contraceptives. You may, if they're on a high dose of estrogen or you had to put them on that, then you'd have to give them an antiemetic because they'll cause, high dose of estrogen causes you to be nauseous. Okay. You might have to do Depo-Provera, etc. So this kind of goes over some of the different treatment. And for very severe cases, obviously they'd have to be hospitalized. Hopefully you won't have that, but you'd be consulting somebody. Make sure you do the reading in the about the treatment management, but oral contraceptive pills generally are pretty much what is done once you do the basics of getting a history and NSAIDs with them. We're back to this again. I want to make sure we go over this and just say to you, caring is a core value of nursing, and one of the major nurse theorists out there, caring is the essence of nursing. Gene Watson. Something for you to really think about when you're taking care of these different populations we talked about, whether it's someone who's dealing with precocious puberty or delayed puberty. Those people require a lot of care and sensitivity. Also, the young woman with abnormal uterine bleeding. So bear that in mind, and leave you with a thought from Maya Angelou.